Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I will be your host. I am here every week with you, and I am a filmmaker and a writer, and I've been working with CCF for a decade, 10 years, creating all sorts of video content, treatment-based videos, patient-centric videos, live video series like the show we're having today, Luncheon with the Experts, but all with the same mission in mind, and that is to raise awareness, spread education about neuroendocrine tumors. So if you are a regular to the show, you're probably already doing what we normally do, which is just signing on, saying hello to the other friends of the foundation in the comment section. If you're new, welcome. Tell us where you're from. I really love to see how far these programs reach every week. And I say this every week. It's astounding to me sometimes how far it reaches live. Other, countries, South Africa, India, Australia, places that you would think would be asleep at this time of day are tuning in. And that says a lot to me about the value and the impact of the show. And that makes me very happy and very fulfilled about the work that we are doing. So before we move forward, we always like to thank our sponsor, Ipsen Biopharmaceuticals, for their support of Luncheon with the Experts. We couldn't do this program without them. And we always have this disclaimer from them, and that says that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, folks. That was a lot. Sometimes disclaimers are wordy, but the takeaway I want you to really grasp onto is, hey, we're going to give you some answers to your questions, some good general advice today, but by no means do we know your specific case. So take those answers, take that general advice back to your home team, which does, and make the best plan and path for you moving forward. As we all know, each case of this disease is totally unique and typically has a unique path. So it really determines on those who know your case. But I think you're going to get a lot of value from today's show, and I welcome you all being here. And I also would like to welcome our guest, Dr. Chandrikha Chandrasekharan. How are you, Dr. Chandrasekharan?
Thank you. Thanks, Rain, for inviting me. And I'm really, really pleased to, this is my first time doing the Luncheon with Experts, and I'm really looking forward to the questions and interacting with patients via your moderation.
Well, thank you. So for those who don't know you or know where you work, tell the folks a little bit about where you fit into the neuroendocrine tumor community.
So I think I've been in the neuroendocrine tumor field for lesser time than you. You mentioned 10 years doing this. So I'm a medical oncologist by background. I train in GI medical oncology, gastrointestinal. So that's not just neuroendocrine tumors, but other cancers in the GI tract. Mm-hmm. But I focus on neuroendocrine tumors, and I've been at University of Iowa now roughly 5 years. And I did a medical oncology from LSU, Louisiana, and also from an advanced year in GI oncology with the Mayo Clinic. And I'm also palliative care trained.
Okay.
So that's kind of my background. I would say I'm mainly a clinician with clinical research as my passion.
Okay.
And a lot of folks may know that University of Iowa is known for as a neuroendocrine center. We have a wonderful team here that I work with, and I learn from every day. And it's a continuous journey for even the physicians and the team involved in taking care of patients.
Awesome. Well, I already have a lot of questions. I'm seeing some of the folks signing on. We've got Ursula from South Africa. Hello, Ursula. A lot of people from Canada and a lot of people from North Carolina, which always makes me happy because that's where I am here in Durham.
Oh.
Tom says, hi, thanks again, CCF Rain and Dr. Chandrasekharan from Liberty Lake. Happy Thanksgiving week to everybody. Okay, folks. So
a disclaimer, if anody wants to call me Dr. Chandrikha, it's totally fine. I don't expect anybody to spell my last name, so Dr. Chandrikha is what I go with. Yeah. So
Gotcha. I made sure, folks, that I try to pronounce it correctly. So let me know if I am. I gave it a stab by myself, and I was pretty close the first time. Okay, so folks, here's the show. Go ahead and start sending in your questions, okay? This show is going to live. It'll be on the Facebook, the videos tab on the Facebook page here. Starting Monday, we will republish it to YouTube, so you can always watch the replay. Go ahead and start sending in your questions, because I think the real value is this interactive one-on-one session, that and the community that we've cultivated here in the comment section. a lot of the comments are you all sharing your experiences back and forth with each other. And I think that's totally valuable. But you'll still get value by replaying this. But if you know someone that would benefit from being here, go ahead and tag them in the comments, share the video to their page, send them a text message, smoke signal, whatever you got to do. Let them know that the show is going on and let them know to get here. But also, if you want to replay it, you can see this video at any time. If we don't get to your questions, please follow up with CCF at carcinoid.org or send them a message here on their Facebook page. We're going to try our best to get to all of them. We can't really get into really case-specific questions, so try to ask them in generic terms. Obviously, Dr. Chandrasekharan doesn't, if she's not your doctor, she doesn't know your specific case, so it's really hard to field those really nuanced and dense questions. So we still want to get you some value and some answers, so try to formulate your questions that way. And my last ask for you all, I say this every week and you all do a great job and it helps me out tremendously. If you see a question in the sidebar that you also have or that you're interested in the answer to, right under the comment, it says like or reply. You can hit that like button and it will effectively upvote that question. If 7 people like that question, I know there's a demand for it. I'm going to make sure I get it across because inevitably we get hundreds of questions and we can't get to them all in one session. That's why we keep coming back every week and we hope that you do too. All right, let's get started. So I have a few questions to get us started. You know, you said you were already, as a medical oncologist, dealing with cancers in the GI tract, right? So obviously that's a lot of nets, but not only nets. What was the moment where your focus started to shift? What was the driving force that made you say like this rare cancer is like there's something here I'm really passionate about, and kind of now you've dedicated your time to that?
I think in many ways for the patients, neuroendocrine tumors are confusing. And truth be told, actually for clinicians too, actually it's very confusing. You know, if you're not, used to seeing patients with neuroendocrine tumors, even for an oncologist, for example, it's just not your routine day-to-day, patient. You know, it's not like colon cancer that you are going to see for sure in your, practice. So just the complex challenges involved with and the multidisciplinary care involved with every single patient, I think was kind of what drew me to neuroendocrine, the world of NETs. It is just so different from the rest. I know that's from it just kind of piques your interest. And I think the exposure that you get during your fellowship also kind of trains you. So when I trained at Mayo, I got to see a lot of patients with neuroendocrine tumors with Dr. Halfdannerson, and so that was another draw to that, tumor. And it's a different relationship. I think all oncologists share a wonderful relationship with patients. I hope the same way for the other way too, because you see them. I sometimes see my patients more often than I see my family. So, and in a neuroendocrine tumor, in the case of neuroendocrine tumors, it's like over sometimes years and even sometimes decades probably, and it's a good thing. And I think it's just a different relationship. So all these things, just the complexity, the just not knowing enough about it makes it more challenging and more interesting as a clinician and researcher. And I think the patient community, of course, it's just a different take altogether. I've also had some family members with neuroendocrine tumors when I did not even know what it was in the past. I wouldn't say that's maybe the reason that draw, but I think that now it all kind of makes like a connection right away. And I'm glad I'm doing what I'm doing because I really, truly enjoy what I do.
Awesome. You said this word family, and I think that you see that in the NET community. To me, it feels that way. I've kind of been on the outside, but been able to be on the inside. So I see, I work with patients telling their stories. I work with doctors. And it is really this strong community, and every expert that we've had on the show agrees, and you feel that, and that's part of what I'm really proud about the show is you see this connection between
Absolutely,
patients.
yeah. I think especially patient advocacy is very strong, which is it's a very good sign. I mean, it's ultimately about taking care of patients, and so when it's driven by them and the group of patients, I think it's very, very much more valuable.
Totally agree. I just wanted to say there's a couple of your patients that are in the audience today, and so they're sending you some love. We have Deb and we have Mary. Deb says it is well worth the 6-hour drive from Kalamazoo, Michigan to Iowa City, even in the winters.
Thank you. Thanks, Deb.
Just wanted to let you know you're already getting some love from.
I don't know. I'm so late in my clinic all the time, so I don't know if it's worth it my time, but.
All right. Well, we got questions rolling in already, so we're going to go ahead and start taking something from the audience. And the first one is from Beth. Beth says, does Sandostatin sometimes cause hair loss?
Does it cause hair loss? The first thing I would think about checking is thyroid function, because we know the injections can mess with your thyroid function and that can have effect on the hair loss. So just one thing medically that we know in direct ways that are direct, cause probably a hair loss problem. The other common things to rule out is still like iron deficiency, patients with small bowel neuroendocrine if they're bleeding or other kind of things. So I would still start out with the differential of what are known reasons for hair loss and make sure those are addressed first, like the thyroid function is optimal, the iron deficiencies, if there or any kind of vitamin deficiencies are addressed because of the GI tract changes before kind of thinking about Sandostatin. As far as I know, that's not like at least a very commonly reported side effect. It's not like chemotherapy, of course, where there are some chemotherapy agents that will cause like hair loss. And some that will cause hair thinning maybe, and some that don't even affect it. So it's definitely not like a primary symptom of it. But it is, I think a lot of patients actually observe more than, and this is all patient reported symptoms. So if there is anything like that going on, like I said, I would start with workup of possible other reasons like the thyroid and deficiencies before we get to the Sando.
Got it. Thank you. And thanks so much for your question. Next question from Barney. Barney says, would you please tell us a bit about the unique tumor specimen stains done at the University of Iowa?
Yeah, so Dr. Andrew Belize is our pathologist who's been with us, and I've learned a lot from him. So I think a few things that are commonly done in any pathology, every neuroendocrine tumor pathology should have these elements. I always educate my patients the first time that this is what we need to look in your tumor. So like the differentiation of the tumor, which basically I describe to patients as how chaotic the cells are compared to like the parent cells. So if it's a well-differentiated tumor, it's very different from a very poorly differentiated tumor. Then usually every neuroendocrine tumor specimen should talk about mitosis and what we call Ki-67, which is basically the proliferation rate. Roughly, if you're looking in the microscope in a certain area of the tumor, you look at how many cells are dividing, you put a little stain on it, and you express it as a percentage, and that's the Ki-67. Mm-hmm. So every pathology, when they call it a neuroendocrine tumor, should have these elements. Usually there's chromogranin staining or synaptophysin staining. So these are kind of the protein things that they put on the dyes, like say, let's call it dyes that they put on the tissue to call it a neuroendocrine tumor. There are some nuances to it too, because there are some tumors that are what we call adenocarcinomas, which is basically the more common variety of ductal elements that you see in these tumors that could have pockets of neuroendocrine looking cells. And that's not the same as neuroendocrine tumors. And we call them adenocarcinomas with neuroendocrine differentiation. So these are kind of the nuances a pathologist who's used to seeing these tumors more likely is going to pick up on. Also, there are some mixed tumors, we call them. There's some neuroendocrine elements and then non-neuroendocrine elements all in the same tumor. So it's very important to get a good path review. As to the unique stains that Iowa does, we kind of do a panel of what we call a tissue of origin test, which is sometimes done in other institutions with expertise with neuroendocrine too, trying to figure out the primary origin of the tumor. So again, there are some limitations with all these tests. So we typically do what we call CDX2, which is usually a protein or a stain that is present in a small bowel origin tumor. And then we do a pancreatic specific stain, and then PAX8 or PAX6, and then there's also one called TTF1 that is for lung. So these are kind of the specific stains to find out the origin of where the tumor could have started. Now, sometimes it's obvious on a scan or a Gallium PET scan, but sometimes it's not, and these tissue testing can help. We also do somatostatin receptor stains. What does that mean? So as many of you may know, the tumors are specific. They're special because they express this octreotide receptors on their surface. And another word for the octreotide receptors is somatostatin. And the specific type, there are like 4 or 5 of them, and the one that's more expressed is the SSTR2A, somatostatin receptor 2A. So we also do stain for that on the surface of the tumors, and we strain sometimes for a marker called CXCR4. Now, the CXCR4 is expressed more commonly in a high-grade or fast-growing tumor. And why do we do that? With the Gallium PET-CT, there have been studies looking at whether the expression of the tumor is better on the immunohistochemistry, meaning the stain versus the Gallium. I would say go with the gallium because you're looking at the tumor expression as a more dynamic thing and a functional thing. And a gallium still is more specific and sensitive for that. But we do kind of supplement it with the stain on the tissue. So these are kind of the basic tissue stuff that we do. Sometimes we do what we call this gets a little bit more complicated, but we get into retinoblastoma staining, RB staining, and TP53. This is more helpful when we're looking at the higher grade tumors that are faster growing. That's where it has more value. So this is kind of the basic panel that we do. And I think the tissue of origin testing is done in many places, but not quite in probably like a community practice, maybe not done. And so that's sometimes helps us to say, okay, we think your primary tumor is from here. So it's a long answer. Sorry, cut me short when I'm going too much.
No, that's all right. Yeah. Hey, thorough. There's not a problem with thorough. Yeah. That's what I like to call it. Barney. Hey, Barney, great question, man. Okay, next. Well, folks, if you join us a little bit late, this is Luncheon with the Experts, Carcinoid Cancer Foundation program. We're here with Dr. Chandrikha Chandrasekharan from the University of Iowa, and we were just talking about some of the work done at University of Iowa. Now, I've been to University of Iowa, worked with both Dr. Odericios and many of the other ones there. What a great multidisciplinary team that you all have there. Talk to me a little bit about why that's so important and you know what makes Iowa's MDT special.
I think the key word for any patient with neuroendocrine tumor is to have a multidisciplinary team, because this is, I have so many things I still don't know, and I just can't do what I do without the whole team support. And typically, like a neuroendocrine tumor team has, I'll explain what Iowa has, and maybe, just in general, like a medical oncologist most often is the first person you see, like me. And I definitely need the help of a surgeon. There are definitely some controversies about surgery, but then a surgeon has a very valuable role. Sometimes an endocrinologist, like in our case on Iowa, Dr. Dillon and Dr. Odericio, endocrinologists by background. And as we know, these tumors secrete hormones and they have symptoms, and there's a lot of other additional supportive care that we need. And so endocrinologists are necessary, or at least need to be keyed in. Gastroenterologist, I think that's very important, because, we talk about diarrhea, we talk about symptoms, we talk about the gut all the time, many times. So a good gastroenterologist who is kind of at least tuned to these and the procedures that we do in these tumors. And we have Dr. Gerke and Dr. Alabia in Iowa that are kind of primary gastroenterologist. Of course, a nuclear medicine doctor, like in our case, Dr. Menda and Dr. Bushnell are our nuclear medicine specialists. They deal with the PRRT, the gallium PET scans, and then interventional radiologists, which is basically the doctors that do the embolization procedures we talk about, or the ablation sometimes. And Dr. Laura here is our specialist in neuroendocrine tumors. So, and then the pathologist I already talked to you is very, very key. Not, if everything comes down to pathology, we have a ton of basic science researchers, Dr. Quell and her lab. So this is, I don't know if I'm missing somebody. So this is already talking about like about 10 disciplines, and I'm missing out on radiology, the doctors that read the CT scans and MRI, because there are so many elements of care for patients with neuroendocrine tumor. And, there are so many options, which makes it confusing as well sometimes, okay, which do I go with? Is it, it's not just all about the drugs and the chemotherapies, which we sometimes use in this cancer. There's PRRT, there's embolization, there's just Statin, and then on top of it, we have to use drugs to control if somebody's tumor is making like a hormone like cortisol. How do we get that to be controlled with the help of an endocrinologist? So we need a scope to look what's going on and where things are. We need a gastroenterologist, and ultimately everything is read by the pathologist and the radiologist. So this is just like a few people that I mentioned in the big team at Iowa that is essentially a necessary element in every care team, and really truly the value comes when we all put our heads together in the tumor board, and everybody has like, oh, what about this, or what about that, maybe we should approach this, what about the side effect from this, it doesn't make sense for this patient. So really it's never or never ever is an individual decision, I would say. It's almost always a multidisciplinary decision or multidisciplinary input. And I know that sometimes takes time, but I think there's value in that.
Absolutely. And
it's important for every patient to seek out their net team, it's very important to go to a high volume center or a center that has these expertise to get this whole overview.
What I'm realizing is, because I talk to the audience a lot about the community that, we've kind of cultivated here, and it's just as valuable in a lot of ways. but I'm seeing now that the doctors have that as well. Like both the
Mhm.
patients and the doctors have these communities that they lean on for one, support, and also for shared knowledge, for their shared experiences. So I like that kind of parallel, that community helps in both ways. I see that with the patients sharing their own experiences, but that's essentially
Absolutely.
what the
Even within
ND.
the physicians, I think
Yeah,
we all are thinking of each other as a family, So I
yeah,
text dial and, I'm like, hey, can you, what would you do in this situation?
right,
Yeah, because it is
totally.
a very complex disease and it needs
Yep.
more than one brilliant mind or more than one mind to be involved.
Yeah, and that's
Yeah.
a theme that always comes back up in the show. So
Mhm.
I love when I see it like that. When we first were talking before we started the show, I mentioned that some of our patients may be new. A lot of them are very well educated. But I talked about laying some groundwork, right? Sometimes we're going to
Mhm.
lay some foundation. Here's an opportunity to do some of that. Mary asked, could you please describe PRRT in more detail, the pros and cons? So let's lay some
Okay.
foundation.
So, so PRRT, there are different words, basically peptide receptor radionuclide therapy. That's what the PRRT stands for. And this branch of medicine is actually even gaining a lot of traction in other cancers like prostate cancer. So another word we would use is theranostics, which is basically using like a radioactive element as a treatment, thing to the tumor. And the basic premise is, there is some kind of a target on the tumor that makes it attractive to deliver this radioactive element to the tumor more specifically. So it's almost like everybody has probably heard the lock and key analogy when they're describing PRRT. So just kind of coming back to that, if you imagine a tumor cell, what's unique, as we talked about these neuroendocrine tumors, is that they express a protein receptor on their surface. And it's either called an octreotide receptor or somatostatin receptor, different names for it. So the first thing we need to check before we talk about PRRT is if the tumor has that receptor. So because if you don't have the target, why are you even using that therapy? And that's often what a gallium PET scan or a copper scan now, which is available, that's what it does to figure out if the tumors express that receptor. So what they do in the gallium scan is the molecule, what they inject in the IV is gallium. So gallium emits photons that helps us take like a gamma ray that helps us take a picture in a camera with special machines, which is attached to the octreotide molecule, which is the actual protein. And then everything is put together to stabilize it. You need a chelator. Chelator is just like a glue, kind of think of it, or a cage. And there are different types of them, like dotatate and dotatalk. So that's like maybe the glue, if you can imagine, that puts together the octreotide and the gallium. And this is what is injected in the IV of the patient. It circulates in your body, and the idea is the octreotide molecule goes and sits on the tumor where the receptors are present. So with it, it takes this gallium and kind of sits on the tumor. And we take pictures and the gallium glows. So wherever there is a glow in the picture, I'm using the word glow just because when patients see the scan, it shows like the bright orange spot. So that's means that there's tumor that's expressing the receptors. And so gallium or the copper, when you switch the gallium to a copper, you get a copper scan. That's how we find out the tumor has receptors. Now, same concept, we switch the gallium to a different molecule. In the case of the FDA approved in the US, it's lutetium-177. So this is a radioactive element which has a different type of energy that it emits called beta rays, which has a little bit, it has a capacity to kind of damage the DNA and kind of cause tumor cell death. So you use the same concept of injecting the lutetium, which is tagged or piggybacked onto the octreotide, put in a little cage with a linker or a glue called a chelator. That is the dotatate. And so the USA approved version is Lutathera, which is basically lutetium with dotatate and the octreotide all packaged well in a stable way and given an IV 4 times every 2 months, once every 2 months or 4, altogether. And that is again delivered. The octreotide goes and sits on the tumors. Lutetium goes with it to the tumors, and the lutetium gets into the cell. And because it's radioactive, it kind of causes the DNA damage to call the cell death. Now, there are definitely steps that we don't know. Always people imagine, oh, this means the tumor is going to explode and die and all those things, right? So if you look at the objective data, what we expect in the NETTER-1 trial that led to the approval, only 17%, which is roughly 1 in 5 that you treat will have a shrinkage of the tumor. And the majority, you expect the stability. I also explain to patients, if your tumor is growing along this curve and you got lutetium, we are hoping it does this for a longer time. So more often we see stable disease, and we do see some responses as well. And there are limitations to it. So if you don't have the receptor, the PRT doesn't work.
Got it.
So that's kind of, I guess, the way I explain the PRT to patients. Yeah.
Excellent. And Mary, thank you for that question, because I've been working with PRT, or not working with PRT, but in the video sense and what I do for CCF for a while, we've made videos about PRT, but the way you explained it was just so helpful for me. I just learned a ton about it. Very comprehensive and thorough, like I said before, but you also explained it in a way that we could really understand. So I appreciate the question, Mary. Now we actually have a follow-up question about PRT from Kathy. It says, and you were kind of getting to this point, so this may be the situation. Can PRRT kill off the less aggressive cancer and then let the more aggressive cancer grow? It seems like this is what has happened with my husband's cancer. He had the first 4 treatments, then an additional 2, and then the cancer grew more after the PRRT. Sorry to hear that, Kathy. Any thoughts?
Yeah, I mean, that's unfortunate, what's happening, I guess there are some theories around it. And I must say, we do clinically see about 10 to 15%, we call them rapid progressors, or, that's a loose term. When I say rapid progressor, what does it mean? Basically you don't get the expected response or stability after PRRT and you have your tumor growing faster. Now, the question of whether the PRT did that to the tumor, or is it the evolution of the tumor, is probably harder to know, because we also see sometimes, which is kind of my area of interest, because when patients have a neuroendocrine tumor of this grade, sometimes we see this evolve into like a faster growing tumor. Like it's, you're like a certain person's tumor grows at a certain pace, which we learn over time. Your tumor grows about randomly, let's say 1 centimeter every year, and then suddenly you get a scan in 6 months and you have 10 new tumors and your tumor just tripled in size, which happens, fortunately very infrequently, but it does happen. And that keys us in that something has changed about the tumor. So that's usually when we biopsy and say there's a higher grade. Now, this happens even without PRRT sometimes. So the question of the theory, I guess, is, does the PRRT kill off this clone of cells, let's say, that are driven by the octreotide receptors, and then you unleash this other type of cells that change the environment of the tumor? I think these are all theoretical discussions, but there are definitely hypotheses going and looking into this. I don't think we know exactly the answers, whether it's the evolution of the tumor or the PRRT has a hand in it, because the majority benefit from it, and that's still the fact, both in terms of survival and response and symptom benefit. So what happens to that small fraction of patients that don't respond well, or who progress, or meaning have more growth, is definitely a big area of interest. And what to do about those patient situations is another big area of interest.
Got it. One more PRRT question. Deb says, what's the latest research regarding PRRT, especially relating to alpha particles?
Yeah, I think this is definitely, I was expecting this question, because I think a lot of people are expecting, are interested in alpha therapy. And this is going to be, I think now that PRRT has been approved, I think there's this patient population that all got PRRT. And I think we're getting to 2-3 years now in many patients where we're starting to see tumor growth. So I'm like, what's next, right? Yeah. So certainly that is the direction a lot of us are also interested in. The field is moving forward. Again, back to the PRRT concept, what's alpha PRRT is, again, it's dependent on the receptors. So it's delivering a radiopharmaceutical, meaning like a radioactive element, piggybacked on octreotide. So it's only for the patients where the tumor has a receptor. If you don't have the receptors, this doesn't make sense. But instead of the lutetium we talked about, which is a beta particle, we can switch it to a different kind of molecule. So when you talk about alpha particle, the ones that are kind of in trials or kind of usually talked about are lead, bismuth, and actinium. There are others too. So these are kind of the 3 elements. And people like, oh, what, you use lead to treat cancer? And we talk about lead causing cancer, and that's another discussion. But there are, let's say, a medical grade lead, if that makes sense. And so a medical grade lead, or modified with a certain element and energy. So when you switch out and the lutetium to these particles, the lead or the actinium or bismuth, that's an alpha PRRT. Are there studies ongoing, or the studies reported? Yes, there are already studies. I think even the bismuth study, the first element, the alpha particle, was reported even in 2014, actually, the first patient in Europe. And it's still like in multiple clinical trials. What's attractive about the lead particles or the alpha particles is a much heavier molecule. And so there is a thought that, almost, I think, 7,000 times heavier or something, and it gets delivered to the tumor better. It is independent of the oxygen situation of the, when of the tumor. So in other words, there are some tumors, we call it hypoxic, which is basically like low oxygen concentration. When that is the case, the radiation doesn't work well, that's emitted by these elements, but the alpha particles seem to be independent of it. And despite having low oxygen in the tumor, they seem to work well. And so there are multiple other advantages: the heavy nature of the particle, the better tumor delivery, even in tumors that don't have a lot of oxygen supply, and potentially lesser toxicity to the bone marrow, and better tumor delivery. So these are kind of the advantages we have seen in animal studies as well as in the early human studies. So that's alpha PRT. And what's being done so far, I think the lead study was reported actually in the NANETS meeting that happened recently from Excel Diagnostics, that showed even 1 complete response and 4 partial responses in patients, about 20 patient series. There was a trial from India, I think about 80 some patients that had bismuth based. Some of them, 1/3 were new to PRT, like never gotten PRT, and 1/3 were after prior PRT, like the conventional PRT. So it seems to have activity even in patients who've had lutetium or Y90 before. So I think we're all kind of looking at it as the next thing. Instead of repeating lutetium, maybe you switch out a particle to have a different way of delivering the energy. So there's certainly a lot of excitement. I think long-term data is still lacking because, with the lutetium and Y90, we have almost 10 to 15 years of long-term follow-up. We certainly don't have that with lutetium, with the alpha. And a plug for Iowa here, because we are developing our lead particle as well. And so we will probably have a diagnostic testing first, like a gallium scan type of a deal, and then hopefully lead on to therapy.
Got it. Well, thank you. And thank you, folks, for your questions about PRT. That was awesome. I got a lot of great information myself there. I hope you did as well. Switching gears a little bit, Rebecca says, I'm getting the COVID vaccine, and I've heard that it causes issues with mammograms. Have you heard this? And if so, do we need to wait to have a mammo, or is it something, or if something shows up on our PET scan? I had a PET scan done yesterday, and there is some uptake in my right breast. It states they do not believe that it is NETs related, but it needs further testing. Any thoughts there?
So I may not be giving you the perfect answer because this is radiology or like imaging related, but I can give a general answer because we are, a post-vaccination. So a couple of things: post-vaccination and post-COVID infection itself. Post-vaccination, we are seeing a lot of what we call axillary lymph nodes, basically lymph nodes in your armpit, usually the arm you got the injection. Even in gallium PET scan, we're seeing those tumors light up like a reactive lymph node. And also the regular FDG PET scan, like the PET scans you get for other tumors. So we're definitely seeing those uptake in those lymph nodes, so we always ask when we see those out of the blue, like these lymph nodes, like, did you get your vaccine? And I've seen it sometimes even up to a couple of months after the shots have been given, kind of linger. And then we are seeing some lung changes if it is because of COVID infection. Now that's different. As to the mammogram question, I don't think I'm the expert in that, so I may defer that. But I know if you have when you're looking at breast cancer, you're looking at armpit lymph nodes. So if you had a vaccine or a booster, maybe you may see some lymph node swelling, and that may confuse us. So again, you still need your routine surveillance. If you do for your mammogram, you need to get it. Maybe good to talk to your physician. Do you want to time it after a certain amount of time after the booster shot, or the vaccine?
Got it. Thank you. Next question from Jenny. Jenny says NET appendix tumors are a common appendix tumor, and it seems that so many providers treat them differently.
Yes.
Why is this, and what follow-up is important?
It is a very complicated question, I would say. And actually, appendix tumors are different because, you could have the regular well-differentiated appendix tumors, but then there are also this more what we call goblet cell carcinoid type of tumors, which is slightly different from like a traditional neuroendocrine tumor that you think about, and more mucin producing types, and a different pattern of spread as well. So that's, I think, why it is. Let me put it this way: it's still kind of a little bit of a mystery still, for there's not a lot of research there. There's not a lot of standard guidelines even within the medical community. And it is kind of a rarer of the rarer type, so that makes it even more challenging to say this is what everybody should do. And again, pathology is very key in those tumors. Like for a traditional well-differentiated neuroendocrine tumor in the appendix, we look at the size, we look at whether somebody needs the right colon removed or just the appendix removed, kind of some of the basic questions that get discussed. Where if it's a 2 centimeter and above, the size of the tumor, typically we advise the right hemicolectomy, which is basically taking a piece of your colon, the small bowel, along with the appendix and the lymph nodes, because the larger the size, the tumor tends to go more likely to the lymph nodes. That's one thing I think it's more commonly accepted. The 1 to 2 centimeter is definitely like an area of controversy. There are some centers that would offer the bigger surgery and some that won't. And then, like I said, the goblet cell carcinoid tumors or goblet cell are treated very differently, almost like sometimes a colon cancer at times with the chemotherapy, for lack of, let's say, better agents and better drugs available at this time. So that is why there is a lot of difference. And that also again drives the, the point that if you have an appendix neuroendocrine tumor or appendix goblet carcinoid, you need to go to high volume center. If you don't see enough of it, you are not going to know what to expect and what to do with it.
Got it. Got it. Thanks, Jenny. And we actually have another question from Jenny. This is scan related, which we talked about a little bit today. And Jenny says the Gallium-68 scan can be controversial in asymptomatic patients for general screening in patient with in asymptomatic patients for general screening in a patient with history. Is it better to just start with a CT or MRI? That's the question.
So I'm questioning, I guess I'm trying to understand the question. Why would a asymptomatic patient need a gallium PET scan is what I didn't understand. I guess the other way maybe is if you have symptoms that suggest and you don't have anything on a CT, that's one time we sometimes consider gallium, but there are a lot of limitations there as well, so like if you're asymptomatic, I'm not sure you would need any scan. I guess I'm not understanding the question.
Yeah, Jenny, if I misunderstood that and you're still around, let me know if you have any clarification. I want to make sure we try to get that.
I can answer the other angle. Maybe if you have symptoms that are consistent with carcinoid or sounds like carcinoid with flushing, diarrhea, and you get a CT scan and, many times you get a random serotonin drawn, chromogranin drawn, and then, it's, I must say this, many times I see patients that have already been diagnosed, so I've actually I'm not doing the hard part of diagnosing it many times, which is actually the harder part sometimes. So in those patients, should we get a gallium PET CT? I would say it's a soft indication because there are false positives with any test, including gallium PET CT. If you have, let's say, a tumor, usually in the small bowel, for example, which is hard to pick up on many regular CT scans, but if the symptoms are there, like a flushing and other type of symptoms, we usually expect liver involvement, and that you should be able to pick up on a CT scan or an MRI or one of the regular scans. Or at least you'll see those lymph nodes. We call them mesenteric lymph nodes, which is in your belly. So that's usually a telltale sign of something going on in the small bowel. So there are some studies that have looked at this, but I think it's the ability to pick up and diagnose a neuroendocrine tumor based on that without anything wrong in a regular CT is very low threshold. Yeah.
Got it. Question from Sarah. Sarah says, will there be a pill form of octreotide in the future sometime?
Yes, I think we're all again looking forward to that. And there are already clinical trials that are running and going to be coming to they're already in the US and there are going to be maybe more. Couple of, I think drug companies are developing their oral octreotide. The challenge is octreotide, the molecule itself is actually digested by your enzyme. So the challenge has been to figure out how to keep it stable when you swallow a pill and then get it delivered into your system. So I think we are there. We're going to be there soon. So hopefully no injections in the future. There are trials. So all the patients who are listening in, please seek out those trials, help participate and help get this drug to get approved. Hopefully if it works, of course. They're probably going to be looking at carcinoid syndrome patients, meaning the patients who have the flushing and diarrhea, because, we know the octreotide has two properties. One is the tumor control and the hormone control. But I think hormone control is going to be where they're going to start out. And then, the details we'll know soon.
Mm-hmm. So Ruby says, when Statin is no longer effective in controlling diarrhea and flushing, what other treatment is available?
And it's a very important and common clinical situation. The first time when somebody has diarrhea like this, I always ask what the diarrhea is from, because you can't always assume it's the neuroendocrine tumor. There are so many other differential, meaning, the other possibilities. So it's good to kind of run through the list every time something is not fitting. For example, a lot of patients with neuroendocrine tumors have had surgeries, gallbladder removed. Sometimes the octreotide itself can cause what we call steatorrhea, which is basically the word for fat malabsorption causing part of my language, stinky stools. That's basically it. And so that is very common with octreotides. It's good to know and get a good history and a pattern of what's changed before we say, okay, this is from the tumor. And the next step I always will do is if there's change in symptom, get a scan or something, make sure the tumor is not growing, because you have to address, if there is tumor growth and symptom worsening, you got to address the tumor probably to help the symptoms. Outside of that, what are the other tools? So everybody's probably familiar with the medication called teletristat or Zermelo, which is an oral pill that can be used for patients who have diarrhea despite being on the long-acting octreotide. And then we can use short-acting octreotide medications. Basically, these are self-injected, like an insulin shot kind of, and they're short-acting, usually 6 to 8 hours. You can use it based on your need. Like if you're traveling and you have a diarrhea or a certain day that's bad, or some people say, the 4th week just before my injection, I kind of have more diarrhea. So that's a little bit more flexible. So again, you have to like needles for now to get that. So that's a short-acting octreotide or Zermelo. And then sometimes traditional Imodium and another drug prescription called Lomotil, which is basically an anti-diarrhea medications. Those are also helpful. Sometimes some patients need all of them. Always look at tumor control if you need it, because that's a good way to address the symptoms, and then have an idea about what is likely causing the diarrhea. Because if it is, let's say, a fat malabsorption deal, because you've been on octreotide for a long time, or you had a pancreas surgery before, then you are going to need some kind of a pancreas enzyme to help digest the fat in your diet, or you got to pay attention to your food diary to like what is causing this potentially. So this is just the general approach to diarrhea in patients with neuroendocrine tumor, when being sure that it's carcinoid versus some other possibilities.
Got it. Folks, we got about 15 minutes left, a little bit more, so keep sending in those questions. We're going to keep churning along, and people are agreeing with me, Dr. Chandrasekharan, about the thorough information, and they're getting a lot of value from it. So we appreciate you being here with us. Absolutely. Linda says, when you have had a gallium dotatate PET scan and they change to a PET copper 64, doesn't that bring you back to a new baseline?
There, again, a better question for an imaging person, like a radiology person, because there are nuances to that. There definitely is a little bit of, even for example, there's, the PET scans are based on like the camera, the sensitivity of the camera can be different between centers too. Like we recently had our PET center cameras updated, and our radiologists, when they were reading it, it's like, yeah, if you compare to an image from 4 years ago when we had the old cameras, your brightness, your sharpness of your image is different. So in some ways, there can be a little bit of, let's say, disconnect or misconnect between the two. But for the most part, I think an experienced nuclear medicine doctor is going to be able to tell that, or at least comment on the possibility of this being, maybe a little different because of a difference in scan. So that is another reason I try as best as possible to stick to one imaging, or as much, like one apples to apples comparison as much as possible, as long as it gives us the information. It's another question that people ask is, how often do I get gallium, or what kind of, test should I get? Should it be a CT? Should it be MRI? And it's a big, long question, I would say we use all modalities in different patients depending on different situations and the tumor location and things like that. For Iowa, we actually make our own gallium DOTA top scan, which is different actually from the net spot, which is different in the glue or the chelator molecule, because we have our own generator and we have an FDA approval for that. So that's, again, another third imaging that's really not widely talked about, but we pretty much use mostly gallium DOTA tops, not DOTA tates. The reason copper is picking up is the ease and convenience. It's, the molecule is much more stable. So many other centers, many imaging centers can get the drug, it's stable, and you can use many doses for many patients. So it's just kind of more convenient that way and practical.
Got it. Karen says, do you recommend getting all hormone levels checked?
The answer is going to be, so I am from Iowa, where there are a lot of biomarkers that we do, and they all have limitations. And I think all neuroendocrine doctors have a love-hate relationship. I'm sure the patients do too with these markers. So with that background, I don't think I get all of them every single time. Now, there are some tumors that make, for example, gastrin or glucagon, or so like some specific secretors, they tend to very well parallel the disease activity. So those definitely I try to get them. At Iowa, we get a pancreastatin, which is not widely available. The pancreastatin, to me, for small bowel tumors especially, seem to be more sensitive. And there's some data and literature from Iowa that has published post-surgery, if you see a decline, correlates with the disease-free interval. So there are specific ones based on the patient again. Chromogranin is universally available, but I always caution patients, there are so many false positives and different lab at different values. So patients get a chromogranin level with your primary oncologist once a month sometimes. I'm like, I don't think that's necessary at all. I don't think it adds any value. It only adds more, tension and more anxiety to it. At certain intervals, I think it makes sense, maybe every 3 or every 6, depending on the disease course of the patient. And chromogranin, because it's most widely available, or the 5-HA, which is often done because of the neuroendocrine, that's the guideline. But we do an extended panel, and then we start limiting it based on what the patient's tumor seems to be, secreting and mirroring that. And I always interpret that in conjunction with the clinical picture and in conjunction with the scans and imaging. I would never change therapy based on just a marker.
Got it. Next question from Barney, who we heard from earlier. Barney says, can you detect hypercortisolism from tumor specimens?
I don't know the answer.
Okay.
So we do stain for gastrin, like Iowa does stain for gastrin in the tumor specimen, which is like another, hormone thing. But I don't think that is diagnostic of a secretor. Like, to say your tumor is secreting and you're manifesting the symptoms, you still have to do the blood test and you have to have a clinical presentation of it. So in other words, if a gastrin tumor, I'm answering gastrin, not the cortisol, but I'm just saying that if you just have a stain positive, I wouldn't call it a gastrinoma based on that. I mean, typically, you have the symptom and the syndrome associated with it.
I want to switch gears a little bit here before we leave. You talked about how much of a passion the research is for you and your work. And I have a question here from Tom. It says, is there a certain place to go to get involved in clinical trials? And so I think you can probably answer that pretty efficiently. But then I also want to learn a little bit about your work. So where is a place Tom can go to get involved with clinical trials?
So I think a bit of education about clinical trials is important just in general, because, this is relevant for other cancers too. Clinical trials, as we call it, experimental therapies, but always patients say, oh, am I being the guinea pig for, for the research? So it's important to know the phase of the trials. We typically put them into phase 1, 2, and 3. Phase 1 trials are kind of very early trials. Most often, or many times, they're like new drugs. Like we have preclinical data like in the lab, and they're trying to get it to the patient. And the focus of the research is often safety, to make sure it's safe, and then to try to find a dose that we can use. And that's a phase 1. And it usually involves lesser number of patients, even less than 10 or 30 sometimes. Phase 2 is the next step often, where we have some safety data, we have a dose, and then we want to test the activity of the drug that we are looking at. Now, sometimes they can be built in like a phase 1/phase 2. So like you do a safety portion and then you move on to the phase 2 portion of the same trial. And then phase 3 is often like a large number of patients, usually in hundreds. And they have a very good defined endpoint of really trying to figure out, does the drug work, and and you have a dose and things. And then sometimes the drugs can be drugs that we use in other cancers. So for example, there's an ongoing trial called Cabinet trial of the cabozantinib. So we have a lot of data about cabozantinib from kidney cancers, but there's activity in neuroendocrine tumors is what we're testing. So it's important to know the phase of the trials. And I know some of the concern patients have is the words that may be used is randomization, blinding, placebo. So what do all those mean? Randomization is usually in a phase 3 trial, typically, sometimes in a phase 2 too, where you get allotted a treatment arm. You get either this or that. A placebo, as we all know, is a sugar pill, or kind of like basically you don't get the drug. And a crossover, what does a crossover mean? Let's say you're on a trial that gives you placebo or the drug. A crossover allows you to get the drug if we find out this is not working, and you find out you got the placebo, it gets you the drug. So that's a crossover. Blinding means you and I both don't know what you're getting. And randomization, I mean, that's and then randomization, like I said, a computer algorithm picks this. So these are words just to get a little familiar when you talk about a clinical trials. As to where to go, I think most often with neuroendocrine tumor being, a rare disease, a large neuroendocrine center is more likely to have a bigger portfolio of clinical trials. It's important to also look at the criteria, because some trials will be after 2 types of treatment, some will be after 3 types of treatment, some will be like when you're diagnosed. For example, the NETTER-2 clinical trial, which is like a Prrt trial looking at these higher grade tumors, Ki-67, 10% and 50%. It's actually looking at upfront Prrt within 6 months of your diagnosis. And then there are trials looking at after you've been on 2 or 3 different drugs. So it's important to get into those details. And that's really what we do to help the patients, and other oncologists and other clinicians do. Where to go? I mean, clinicaltrials.gov is the one way to look up what's going on, but it can be overwhelming, because if you put neuroendocrine tumors, sometimes you get melanoma, small cell lung cancers, all in this mix of things. So I'll kind of always say, know where you're looking, what to look. There are ways to search on a map on that. So ask your doctor, the best thing. And if the doctor doesn't know, there's always a patient community, and there are many other organizations where you can get this information of what's going on. And your best bet is always a high volume neuroendocrine tumor center. There are trials that are also open in smaller centers. For example, the cabinet trial I reference, it's open through what we call an alliance, like a cooperative group. So it may be available at a community oncology center as well. So depending on the phase of the trial, the convenience, the ease, it can be in different places.
Got it. Thanks for that. A couple more questions. We've got just a little under 10 minutes left, folks. Rebecca says, how often should we get our serotonin level drawn?
The answer, again, coming to the biomarkers, is typically I try to draw them when we're doing an imaging study to kind of correlate with that. And, so depending on the patient's individual situation, it could be every 6 months, sometimes once a year. I don't think there's value unless there's a clinical change. If your symptoms are changing and things like that, then you could do it more frequently. I don't definitely see value in doing it once a month, like I said. I mean, again, if it's a truly indolent, slow-growing, well-differentiated neuroendocrine tumor.
Got it. You may not, this is kind of about lungs, so I'm not sure, but I'll ask the question anyway. Melinda says, does carcinoid tumorlets in the lungs mean that you have neuroendocrine cancer?
So I don't know if the particular patient is asking or in reference to what we call a dip neck, because we use the word tumorlets in that situation. I do see some lung neuroendocrine tumor too.
Okay.
So lung neuroendocrine tumors are very different. Their classification is different. They just are a different thing altogether, I would say, in how we deal with it. And I'm assuming the tumorlets refers to, sometimes we get a patient where the CT has multiple, what we call nodules, which is like the general term, throughout the lungs scattered, and you put a biopsy needle, it shows neuroendocrine tumors. And when you get a gallium, sometimes these could be like lighting up. And I'm talking about like something as small as a few millimeters, like little dots, to a few like bigger centimeters. So usually they are very small. And we refer to that entity as dip neck, which is basically diffuse idiopathic pulmonary neuroendocrine hyperplasia. That's kind of the word for it. It's again one of those very rare subtype, which is in some ways related to the neuroendocrine tumor, but we don't usually associate a spread from that disease. Like it doesn't spread to the liver or bones or other areas. Typically may not secrete hormones, but sometimes patients may have like a cough or wheezing kind of symptoms from that. So I presume the question is referring to that when they say tumorlets, because another word we use for that is tumorlets. And that's again a very big, it's a bit of a mystery, I'll say, this tumor. And there are very few series that talk about, describe it, or tell us what to do with it. Sometimes we dive some steroids, inhalers, not the traditional neuroendocrine tumor therapies.
Got it. So we've got a few minutes left. I wanted to know a little bit more about where palliative care fits into your practice. Can you talk to me a little bit about that and why that's such a part of what you do?
I think the one thing I would like to clarify about what you define palliative care as,
Okay,
right? I
fair.
mean, in it, I guess, you don't usually use that word or ask the question in the context of a neuroendocrine tumor, but I think it's very relevant. Palliation, as the word means, is palliation, palliating symptoms, palliating, basically quality of life, focus. I kind of would like to call, when I was doing palliative care fellowship, I used to introduce myself as a quality of life doctor, which is just kind of a better term for it, or symptom management doctor. Because truly that's the goal of a palliative care physician. And I think I truly try to palliate in everything and every day that I do, because our goal is quality of life and symptom management in neuroendocrine patients too. there is the spectrum. We talk about hospice when patients are nearing the end of life. We talk about hospice. This disease is so different. How does, we still don't know what are the triggers to call a palliative care consult. I think sometimes an uncontrolled symptom in other cancers is often one of the situations palliative care is talked about. Now, in neuroendocrine tumors, diarrhea, for example, is a different beast in neuroendocrine tumors, and we have other tools than the ones that the palliative care physicians may use. But let's say pain management, if somebody has diffuse bone metastasis and pain from that, I have a certain amount of knowledge about opioids, meaning like pain medications and things, but I'm going to ask my palliative care colleague to help me. Hey, this is getting a little bit more complex. Do we need to do more than this? So that's one way palliative care can fit in any time along the course of the disease. As much as I hate to say and discuss this, the fact is, unfortunately, patients with neuroendocrine tumors also die from the disease. And there's a symptom burden associated with it. There's grief associated with it. There's this anticipatory grief associated with it. There is this anxiety about prognosis. It's so hard to prognosticate, even as a clinician, about this cancer. Do I have 5 years? Do I have 10 years? Do I have 1 year? Right. And I think my training as a palliative care physician helps me answer, or I guess I will say I'm more comfortable with the gray zone because of that. It doesn't make it easy for the patient. But those are also situations when we need help from palliative care. So I don't think there's any situation where I don't see them helpful. Maybe it's not part of your routine consultation in the beginning and you don't need them because they're not going to add value to your care right away. But it is when someone mentions palliative care consult to you along the disease course, I just don't want people to panic and say that's bad. I'm going to, it just means something is going on. It could be for symptom management. It could be for supportive care. It never hurts to have another expert in the team looking at your quality of life as the only focus.
What's your advice for someone who disagrees with something their palliative care doctor says? Rebecca says, my palliative doctor told me that I should go on disability, but I don't feel like I'm at that point yet.
That particular question will be hard to answer without details. And I don't think, disability determination is that easy in this disease because, I'm sure patients agree with that too, because it's unlike other things. I think the patient should do what they feel comfortable with always first. So despite what the physician's advice is, I think the patients know their body best. That's my first answer. I guess I'm not sure about the specific circumstances. Sure. In general, if you disagree with the physician's advice for any reason, or physicians disagree with each other for any reason, the first thing I try to explore is why and what's the other person thinking. You got to meet them what they're thinking. Unless you ask the question, you can't make assumptions. I think we all sincerely try to do that first. And that may actually solve, I guess both of us are thinking the same thing in the end. So, sometimes that's what ends up being.
Yeah, absolutely. Final question. What's coming down the pipeline that has you excited? Anything that you're looking forward to in terms of treatment capabilities, diagnosing?
So I think we already discussed a couple of things, the alpha Prrt, and we talked about the oral octreotide. And I think one drug that hasn't been mentioned today or have been asked about is this drug called belzutifan, which is like a new drug in its own category that's, FDA approved now for VHL-related neuroendocrine tumors, which is like a specific genetic syndrome, but it's going to be tested in other neuroendocrine tumors too. So those are some of the exciting drugs. There's still this question about another drug called Pseudophatenet, which has data from China. It's kind of a cousin of sunitinib or cabozantinib. So these are definitely drugs. This is another disease that always needs more tools. You never, the more the tools, even though it adds confusion as to the sequence and where to do what to do. Hey, I don't think any patient or physician is going to complain about having a lot of tools, and the fact is I tell patients you're going to use a lot of tools and sometimes reuse the tools. So I would say these are the things that are exciting. At a molecular level, like a basic level, I think this focus on the Prrt progressors or non-responders, can we do anything to make the expression of the receptors go up? Especially in the lung neuroendocrine tumors, there's some focus on that, some drugs that are being looked into. That's another area. So we include more patients in that Prrt pot. Those are areas of interest.
Awesome. Well, folks, that is our show for today. I appreciate you being here. And Dr. Chandrasekharan, thank you so much for your time. Everybody is very appreciative of your answers, as am I. I appreciate you being here.
Thank you so much. Thank you for the opportunity. I really, truly enjoy interacting with you, Jane, and with the patients. Yeah.
Absolutely. And folks at home, thank you again, as always, for being here. Again, a reminder, if we didn't get to your question or you have follow-up questions, reach out to Carcinoid Cancer Foundation, either here on their Facebook page or at their website, carcinoid.org, or tune in on Thursdays to the show, because we keep this show going and inevitably we will get to those questions. Thanks, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. And finally, my name is Raymond Bennett. I have been your host. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.
Thank you, everyone. Thank you.